Good afternoon, everyone. Welcome to today's session of Cuddles Online Neonatal Education. In today's webinar, we will discuss about the skin care and other important aspects of pathology related to the neonatal skin. We will also have a brief overview of the structure and development of the skin and the importance of the skin, and also the manifestation of various benign neonatal conditions and the appearance of the skin lesions in various serious systemic manifestations such as hereditary and inherited congenital neonatal disorders and also infectious disorders of the skin. We will also be seeing about some of the common spotters or OSCEs related to the skin conditions. So, coming to the importance of the skin, we all know that the skin is the largest, not only the largest organ of the body, and it also plays an important role in the prevention of infections and is the first line of defense, particularly in identifying between the self and the non-self. So, it forms an important layer, and it is also an organ which is not only easy to observe for any problems, but also it bears the brunt of various hazards like infections and toxins and helps in protecting the body from the same. So the skin acts as a barrier in the prevention of infection. It also plays an important role in thermoregulation and insensible water losses, and it also maintains the body's electrolyte balance and helps in preventing the infection by various cells which are present in the skin like Langerhans cells and T cells and lymphocytes and other cells, and it also helps in preventing the absorption of toxins, and it also plays a role in immunoregulation. So whenever we first see the baby, that is during the resuscitation, it is important to first dry the baby in order to prevent the hypothermia by insensible water losses from the skin in the case of a term baby, whereas in a premature baby, less than 32 weeks, we apply the Cluzy skin plastic wraps to prevent the hypothermia. The skin also helps us to assess the color and perfusion of the baby, which is very important in determining the overall health of the baby. And also, it is a manifestation in different systemic conditions. Like if we see cyanosis, we can predict whether it is due to hypothermia or any underlying cyanotic congenital heart disease. Jaundice also we observe by looking at the baby's skin by the Kramer's method. And we can also observe the pallor of the skin, which can be either due to anemia or due to systemic infection. And vesicles can be secondary to any infections of the skin or congenital inherited vesiculobilous disorders. And petechia can be a sign of low platelet counts and systemic sepsis in a baby. We will also observe whether the skin is either warm or cold to touch, whether it is scleromatous, and whether it is meconium stained or not. So next, coming to the gestational age assessment, the skin plays an important role in the gestational age assessment of the baby by looking at the color and blood vessels, and also the lanugo, we will assess the gestational age. So certain benign conditions versus systemic condition also we will be going through in this topic. Skin plays an important role during the kangaroo mother care and skin-to-skin contact, which we do in term babies soon after the delivery and also in premature babies. It helps in controlling the hypothermia and improves the maternal-infant bonding as well as the feeding of the baby, and also helps in reducing the incidence of hypoglycemia. The maternal-baby bonding or the skin-to-skin which we give during the KIMS or STS also helps in transferring the important microbiome and also helps for the baby to achieve the good microbiota and also help in fighting off the infections through the transfer of the same immunity through the mother's breast milk. So this is the New Ballard's physical maturity scale. If we can see in this picture, we are seeing the babies of different gestational ages ranging from extreme preterms to term baby and also a post-mature baby. Post-dated babies usually have a dry scaly skin which is due to the loss of the vernix caseosa as the baby becomes more mature and leads to drying and peeling of the skin. So just by looking at the baby, we can tell whether the baby is a extreme premature baby or very preterm baby or a term baby or a post-term baby. So if we see the rating, so it starts from -1. If the skin is sticky, friable and very transparent, we give the score of -1. We will give a score of 0 if it is gelatinous, red and translucent. Then it becomes smooth and pink with visible veins, followed by superficial peeling and plus or minus rash and few veins. Then as the skin becomes more and more mature, it leads to cracking in pale areas with rare appearance of veins. Then becomes parchment and deep cracking with no vessels at all, and the final stage is leathery, crackled and wrinkled skin. So we can also assess the gestational age with other parameters like the lanugo, which is abundant in a preterm baby. Later on, it leads to thinning and followed by the bald areas. We will also assess other parameters like plantar surface, breast bud, eye, ear, and genitals. We will not go into the details of the new Ballard score now. I just wanted to highlight the importance of the assessment of gestational age by seeing the skin of the baby. So now coming to the development of the skin, the development of the skin layer starts early as 8 to 10 weeks of gestation inside the womb. So initially the baby will be having only the dermis and a few layers of the basal layer, then followed by the gradual evolution and maturation of the other layers of the epidermis. So initially it is called as periderm, which later on gives rise to different layers of the epidermis. So the epidermis structure forms by around 24 weeks of gestation, and it consists mainly of keratinocytes and melanocytes. The epidermis is divided into different layers like stratum corneum, granular layer, spinous layer and basal layer. So the premature baby contains lesser number of these stratum corneum and granular layers. As the baby matures, this number of thickness of the layers increases. So the stratum corneum is the layer on which we apply the adhesives, temperature probes and such things, which is more prone to the friction and denudement also. So as the baby skin matures, the Langerhans cells and Merkel cells, they percolate into the epidermal layer and they help in offering the local skin immunity. The skin matures after birth of the baby by around 2 to 4 weeks. So that is why when the baby is born as less than 32 weeks, we offer the incubator care for the baby to prevent the insensible water losses and also help in skin maturation. So the dermis is the lower layer of the skin. So in which there will be two different divisions called papillary dermis and reticular dermis. So between the epidermis and the dermis, so there will be a basement membrane which helps in anchors the epidermal layers to the dermis. So the dermis consists of collagen, elastin, blood vessels, nerves, sweat glands and hair follicles, and this helps in offering the elasticity to the skin and also acts as the layer which holds the appendages of the skin. The dermis consists of fibroblasts, histiocytes, macrophages, lymphocytes and neutrophils. The subcutaneous layer, which is very deficient in preterm babies, offers insulation and protection to the skin of the baby. So now coming to the risk factors for skin injury. So what are the main risk factors? Prematurity is a very important risk factor for skin injury, then followed by the application of the monitoring equipment, probes, temperature probes and saturation probes. That is why in preterm babies, we first should offer a layer of skin protection by applying a sterile gauze and then applying a probe on top of it to avoid the skin injury. Then the adhesives which we apply on the skin, for them also before directly applying them to the skin, we should apply a skin friendly adhesive. On top of that, we should apply the adhesives either for the ET tube or intercostal drainage tube or any tubings which need to be adhered to the skin of the baby. Then the other risk factor or immobility of the baby, either due to mechanical ventilation or sedation, also leads to ulceration in the dependent areas of the baby and formation of dependent edema and skin injury and damage. And the various respiratory supports like the application of the CPAP nasal interface can also cause the nasal injury in premature babies, which can be avoided with frequent monitoring. And the medications like inotropes, calcium, and bicarbonate can also lead to extravasation and leads to skin injury and necrosis in the babies. Thermal injury is another component which should be avoided by stringent monitoring of the temperature of the baby by the application of a temperature probe on the um, uh, abdomen of the baby, where just above the liver area, to monitor the temperature of the baby and avoid the thermal injury of the baby. Hypothermia and hyperthermia should be strictly monitored and should be avoided for appropriate skin care. So coming to the unique aspects of the preterm skin, as we discussed, the preterm skin is developmentally and functionally incompetent. The structures of the stratum corneum and the number of layers will be very less, thereby precluding the baby skin for skin damage. The preterm baby skin is also deficient in vernix caseosa, which starts forming after 33 weeks of gestation and becomes abundant in a term baby. The immature immune system of the baby also leads to lesser number of lymphocytes, Langerhans cells, and other immune cells in the skin layers of the baby, putting the baby at risk for increased skin damage. If you compare the term baby, the preterm baby's skin will be like large, surface area will be large compared to the body mass of the baby, and because of the thin layer of the skin of the baby, it is also prone to increased transepidermal water losses compared to a term baby. So initially at birth, the pH of the baby's skin will be alkaline. Later on, it becomes acidic. So this forms the acid mantle of the baby's skin. This acid mantle will be incomplete in a premature baby. This helps in protecting the baby's skin. So these are the differences between the premature baby skin and term baby skin. The premature babies also have less vasomotor control. Thereby, we can see more of the mottling and libido reticularis in a preterm baby. Because of the thin skin of the preterm baby, they are also prone to more absorption of the percutaneous toxins and thereby leading to the side effects of the same. So these are some of the compounds, and with potential of having the percutaneous absorption, we will see one by one. We know some of the things like benzocaine and prilocaine. If they absorbed systemically, they tend to cause methemoglobinemia. Corticosteroid excess can cause adrenal suppression and skin atrophy. Neomycin can cause neural deafness. Povidone iodine can cause hypothyroidism and goiter. Silver sulfadazine can cause kernicterus. Isopropyl alcohol can cause cutaneous hemorrhagic necrosis. Salicylic acid prone to cause metabolic acidosis and salicylum. Boric acid, which is a component of baby powder, sometimes causes vomiting, diarrhea, erythroderma, seizures, and death. Mercury can cause rashes and hypotonia. So we should be aware of the different chemicals in various compounds which we are applying on the skin of the baby and the potential complications of the systemic absorption of the same before we apply to the skin of the baby. So in extremely preterm babies, we generally avoid using the povidone iodine and also use the lesser concentration of the skin preparation. So whenever we are doing the procedures to avoid the skin injury for the same. So coming to the general aspects of the skin care, so whenever we are attending the delivery of a baby, if it is a preterm baby, immediate drying is recommended to prevent the hypothermia. If it is a baby preterm, less than 32 weeks, we should wrap the baby in a plastic wrap and put a cap to prevent the hypothermia. So for term babies, we should leave the vernix intact because that helps in preventing the hypothermia and also protects the skin of the baby. We should advise the parents to delay the bath for 24 hours. We should also train the nurses for the same. WHO recommends at least 6 hours. To avoid damage to the acid mantle of the skin, we should always prefer the neutral pH cleansers and we should avoid the alkaline soaps whenever we are prescribing the same to the babies. Emollients are good to apply for the skin of the babies, particularly in babies with inherent skin conditions called ichthyosis. These help in, and atopic dermatitis, they help in retaining the moisture of the skin. We should use any adhesive sparingly and offer gentle removal of the same. Regarding the cord care, WHO recommends just clean cord care, keeping the cord dry and open. The diaper should be applied below the cord area to prevent the natural drying and fall of the cord and prevent the wetting of the cord. so that the early detachment of the cord will be seen. But there are some studies comparing the application of chlorhexidine versus routine care, which I will show in the next slide. And we should also be aware of the composition of the topically applied agents. Coming to the oil massage, which parents generally do for term babies, so this has been passed down through traditions and generations immemorial. So there have been some studies on the application of oil and the benefits for the babies. So oil massage helps in the benefits being helps in better weight gain. The baby also will have good sleep wake pattern. So it offers the lubrication to the skin and the skin will be soft and supple. The baby will have good sleep wake cycles and infant behavior will be smooth. And it also prevents the hypothermia. It also facilitates the transcutaneous absorption of fatty acids and has been shown to help in the weight gain. So oil massage can be offered to babies, but the hazards in preterms being increased chances of infection and rash. So we should be a bit cautious of applying oil in preterm babies. For routine term babies, we can offer the oil massage. The oils being safflower and coconut oils have anti-inflammatory and antibacterial properties. Olive oil has been shown to increase the pityrosporum growth. Therefore, it should be avoided when we advise the oil massage to the parents. So coming to the study regarding the application of chlorhexidine for the umbilical cord. So in a randomized 6 RCTs have been studied in this study. Single or multiple chlorhexidine cord applications on the neonatal mortality rate and the incidence of systemic sepsis and omphalitis have been studied. So in this systematic review, 6 RCTs have been considered. Among them, 4 are community-based and 2 are hospital-based. There was definitely a benefit in areas which had high rates of home births, particularly more than 92% with high neonatal mortality. So the application of chlorhexidine multiple times, so until the first 10 days of life, has been shown to reduce the incidence of systemic sepsis and omphalitis in areas with high NMR, but there is no difference in hospital-based settings and where the NMR is very less. So in routine hospital settings, chlorhexidine for cord application over the umbilical cord is not recommended. It is only in areas with high neonatal mortality rate. So when we apply the chlorhexidine, it also delays the time for the umbilical cord separation by 2.11 days. So next, coming to the skin care in the NICU, as we discussed, we should always apply the skin friendly adhesives like Deodam and Tegaderm before we apply the Dynaplast, and these should be gently removed by applying sterile water and avoid traction of the skin while removing the tapes. And whenever we are placing an IV cannula or central lines, the dressing should be transparent dressing and it should be inspected daily for any seepage of the blood, and if it is soiled, the dressing should be changed. And we can also observe the erythema and redness of the skin over the insertion of the cannulation site. So this should be taken care. And for babies less than 32 weeks and less than 1200 grams, it is better to prefer the humidified incubators, which help in decreasing the transepidermal water losses, help to maintain skin integrity, and also decrease the fluid requirements of the baby and helps in minimizing the electrolyte imbalance. We should avoid the temperature thermal injury in radiant warmers by placing the probes and monitoring the same in servo control warmers. Adequate nutrition is also important in improving the immunity of the baby and thereby helping in the skin maturity and preventing the skin injuries. There should be proper equipment cleaning protocols like cleaning of the incubators and radiant warmers and the probes to avoid the contamination of the skin of the baby and harboring of the pathogenic microorganisms. So this is the peripheral IV cannula assessment tool. It has been graded from 0 to 4. So grade 0 is okay. There are no symptoms and the cannula is flushing with ease. Grade 1 is localized swelling and flushes with difficulty with pain at the site. So we should try to change the cannula at this grade itself to prevent the extravasation and swelling. The severe grades being grade 2, slight swelling involving 1/4 of the limb with pain and redness. Severe grade is grade 3 with a swelling from 1/4 to half, and the skin becomes cool to touch and becomes blanched with poor pulses. The severe grade 4 being severe swelling more than half of the extremity. So this happens because the cannula with the IV fluid on flow was left unattended. So we should emphasize on every hourly monitoring of the cannula, particularly when the baby is on IV fluids, and more frequently when the baby is on any inotropes, calcium and bicarbonate. So this also can lead to skin breakdown, necrosis and blistering with capillary refill time of more than 4 seconds and absent pulse. This can also lead to loss of the limb. So we should be very careful. At the earlier grades of the swelling itself, the cannula should be replaced. So now let us see the common neonatal disorders. These can be breakdown into the common newborn dermatosis, which are benign, and melanocytic lesions, and hereditary skin lesions, vesiculobullous disorders, which can be infective, hereditary or non-infective types, various infections of the skin, which can be the cutaneous manifestations of the systemic disorders, and vascular malformations, example, the salmon patch, port wine stain and hemangiomas, lymphangiomas, that is cystic hygroma, inflammatory disorders like atopic dermatitis, diaper dermatitis and seborrheic dermatitis. There is an entity called blueberry muffin baby, which can be seen in some infections, particularly the torch infections and histiocytosis, neuroblastoma, leukemia cutis, transient myeloproliferative disorders, and mastocytosis. So, if we see this blueberry muffin kind of rash in a baby, so we should evaluate for the same. In the upcoming slides of this presentation, I will be showing some of the spotters related to these different skin disorders. So you can either answer or type in the chat box. So can someone tell me what is this on the baby, what we are seeing? Dr. Kirtana, Dr. Supraja, any one of you can answer. So this is commonly seen after the birth of any term baby. We can see a white layer on the surface of the baby. So this is the vernix caseosa. So the vernix caseosa help in protecting the skin of the baby by preventing the hypothermia. It is composed of both water and lipids of sebaceous origin and also few corneocytes. It is a hydrophobic in nature, and it is composed of wax esters, cholesterol, ceramides, and squalene, and it is also rich in innate immune factors like lysozyme, lactoferrin, and antioxidants. The vernix caseosa has anti-infective, antioxidative, moisturizing, and cleansing properties. So we should never try to forcibly remove the vernix caseosa after the birth of the baby. So normally the pH of the skin of preterm and term infants is more alkaline, as I discussed, but it declines within the first week to acidic values of 4 to 5.5. So that's why we should prefer the soaps which are neutral or acidic in pH. So the vernix caseosa should not be forcibly removed. It gradually absorbs and helps in maintaining the temperature of the baby during the first 24 hours of life. Bathing should be preferably delayed by 24 hours, and it can be offered weekly twice or thrice in the first few days of life so as to prevent the hypothermia. The bath should be quick within 5 minutes so that the baby does not have too many temperature fluctuations. So let us move on. So we will see some of the transient cutaneous lesions. So what is this one? We can see the few white to yellow colored papules on the nose of the baby. This is also a common, very common finding. So which we see in the term newborns. So this is the milia which appear from the transiently on the nose, and it disappears within the first few days of life. So what are these papules, which can be solitary or multiple on the roof of the hard palate? These are the Epstein's pearls. So both of them have an ectodermal origin. These are epidermal inclusion cysts. So the milia, as we discussed, appear more on the cheek, forehead, nose, and nasolabial folds. They are keratogenous cysts. They can be either single or clustered yellowish white papules. They disappear spontaneously and doesn't need any treatment within the first week of life. So next, moving on to this, can anyone tell what does this picture show? Dr. Tirumal, Rashekar. So if you try to answer, these are all very important for your ASCIIs. So one or two images may be kept and you will be needed to answer the salient findings of the same. I will tell the first one is the bones nodules. So the bones nodules are seen over the buccal surface of the mucosa or the gums, oral mucosa. So these also resolve in 2 to 3 weeks. They can be sometimes mistaken for the natal teeth. So bones nodules can be identified on the buccal surface of the gums and they appear as a whitish papules on the surface of the gums. So this is the sebaceous gland hyperplasia. We can see yellow-white papules grouped around the follicles. These can be secondary to the maternal androgens or the androgens within the baby itself if it is a male baby. So these can be confused with milia, but these have a slightly greasy appearance. These are also harmless lesions which disappear over a few days. So here we can see a blister kind of the thing over the finger of the baby. The same can be seen over the upper lip of the baby. So these are called as sucking blisters. So in the intrauterine period, it shows that the baby had been sucking on the vigorously over the finger or the upper lip. So on the upper lip, these are called as sucking pads and calluses. They are also harmless conditions which disappear over time. So here we can see a spider web like erythematous and appearance followed by areas of pallor. So this is known as the cutis marmorata. This is more often seen in a preterm baby than a term baby. So mottling, if the baby is otherwise stable and clinically well, then we can attribute this as a cutis marmorata. If the baby is sick, so with other parameters like BP fluctuations, poor pulses, feeble pulses and cyanosis over the peripheries, temperature instability, lethargy, then we should always rule out the sepsis. So in preterm babies, the cutis marmorata is a reticulated pattern of constricted capillaries and venules. So it is due to autonomic instability, which we had discussed in our earlier slides, which preterm babies more likely have. It is seen as a response to cold and stress. If the baby is otherwise fine, this resolves over a period of few days. So we can also offer warm care and KMC to the premature babies. So if the cutis marmorata is localized over a limb, then it is called as telangiectasia congenita. Persistent cutis marmorata beyond 1 month of age can be associated with genetic abnormalities such as Down syndrome, trisomy 18 and Cornelia de Lange syndrome, and we should evaluate for the same conditions. So whenever the baby is delivered, as soon as after birth, we see some bluish discoloration over the feet of the baby. So this is known as acrocyanosis. This is also a harmless condition. So it is a response to the cold environment which the baby faces as soon as the baby is born. It resolves spontaneously. We should try to swaddle the baby as soon as examination is done and offer the baby for skin-to-skin contact and breastfeeding. So this is also one of the commonly observed lesions over the skin of the baby during the first few postnatal days. This is erythema toxicum neonatorum. Here we can see a flea-bitten appearance with erythematous red-colored papules on a yellowish white papules on an erythematous base. So these lesions do not appear on the palms and soles. These are also benign self-resolving lesions which disappear over a few days. We need not apply anything for this like oil or any creams. Nothing needs to be applied. It resolves self on the self by 4 to 5 days. If we do a gram stain on the surface of the papules, we can see the eosinophils. So the differential diagnosis being infective conditions like candida, staphylococcal infections and herpes infections, which we see in the subsequent slides. What we can see in this picture, we can see a baby with a slightly more erythematous part on the dependent area when compared to the upper part. So this part appears lighter when compared to this part. This is also a benign condition called harlequin skin change. So So this can last for up to 30 seconds to 20 minutes. This is also due to immaturity of the hypothalamic center that controls the dilatation of the peripheral blood vessels. So this was similar to the erythema toxicum neonatorum, but there is no erythema surrounding the papules, which we can see on the skin surface. So this is a transient pustular melanosis. We can see multiple pustules on the surface of the skin of the baby with no underlying erythema. So we can also see a collarette of scales and pigmented macules. So pigmentation is the characteristic of transient neonatal pustular melanosis. This can also last for 3 to 4 weeks. If we do gram stain from the scrapings of the pustules, we can see neutrophils and eosinophils. Differential diagnosis for the same being staphylococcal pyoderma and congenital cutaneous candidiasis. So here we can see the erythematous lesions over the cheeks and chin of the baby with sparing of the lips. So this is acne neonatorum. So this is also seen in 20% of the newborns. We can see closed comedones on the forehead, cheeks, and also nose. This is due to the stimulation of the sebaceous glands, either due to maternal or neonatal androgens. Usually treatment is not indicated. We should avoid overwrapping of the baby and should also avoid oil massage. It is also a self-limiting condition. So here we can see small crystalline lesions over the skin surface of the baby. This is due to the occlusion of the sweat glands. This is called as miliaria rubra. There is no underlying miliaria crystallina, sorry. There is no underlying erythema. This is due to partial closure of the eccrine structures or sweat glands of the skin. We can see 1 to 2 mm vesicles without any erythema. So it usually occurs on the head, neck, and trunk of the baby. So this is also a self-resolving condition. The another condition is called as miliaria rubra. Here we can see the erythema surrounding the same small vesicles. So this is also called as prickly heat or heat rash. So miliaria rubra is due to obstruction at a deeper level of the sweat glands. So small erythematous papules and vesicles are usually seen on the covered portions of the skin, where there will be more of sweating and increased moisture and increased heat over this area, like diaper area and axillary areas and neck folds and over the back. So for this we should avoid overheating and overclothing of the baby. So recurrent episodes of pustular miliaria rubra is a sign of a fatal condition called as type 1 pseudo hypoaldosteronism. If a baby presents with recurrent lesions of the miliaria rubra, then we should evaluate for the underlying condition. So usually after the first few postnatal days, the parents bring the baby with this kind of lesions over the scalp. So this is the seborrheic dermatitis of the scalp. We can see greasy patches, erythematous and greasy scales over the scalp of the baby. The same can also be seen over the neck folds of the baby. This is commonly called as cradle cap or seborrheic dermatitis. Occurs on the face, neck, ears, and scalp. This can also be secondarily due to fungal infection by Malassezia furfur. Generalized seborrheic dermatitis, failure to thrive, and diarrhea. We should think of immunodeficiency. So for this condition, we should offer the gentle removal of the scales followed by the application of tar-based shampoo. In severe conditions, we can also offer the antifungal shampoos like miconazole or ketoconazole. This also resolves spontaneously over few days to months. So here we can see a hyperpigmented. So till now we have finished the benign skin conditions. We will see some pigmentary conditions. We can see some hyper grayish to green hyperpigmentation over the back of the baby. So this we also commonly seen during our postnatal neonatal rounds. So this is the dermal melanosis or Mongolian spot. This is common in the Asian babies. The most common area being the lumbosacral area. So gray-blue spots will be seen on the skin which lack a sharp border. Usually size will be around 10 centimeters. They gradually disappear over an age of 1 year. Extensive Mongolian spots are associated with inborn errors of metabolism like Hurner syndrome, GM1 gangliosidosis, mucolipidosis, and neurocristopathies. So whenever the parents ask us about this, we can reassure them that it is a spontaneously resolving condition. So if extensive areas are seen, then we can offer the evaluation for IEMs by offering them either TMS or newborn screening. So coming to the vascular lesions on the skin of the neonate, here we can see a erythematous lesion over the eyelids, in between the eyebrows, and also the nose and upper lip of the baby. So this is the salmon patch, or so this is also seen on the posteriorly over the occipital area. So this we commonly see in babies who come to the OPDs. So this is the salmon patch, or also called as nevus simplex. It's also benign, harmless condition. We can see small pale pink ill-defined vascular macules which are centrally located usually. They blanch to touch. They occur on the glabella, eyelids, upper lip and nuchal area, commonly seen in 30 to 40% of neonates. This is due to localized vascular ectasia. If it is seen in the glabellar area between the eyebrows, it is also called as angel's kiss, and these are also called as stork bites. They gradually disappear over the first 1 year of life. So here we can see slightly more erythematous rash usually on the one side of the baby's face. This is the port wine stain. This is seen in a lesser incidence, around 0.3%. It is also called as nevus flammeus. So it's a flat patch of purple or dark red skin with well-defined borders. This is due to capillary hematoma, the most common location being over the face. If it is extensive, we should also rule out the Sturge-Weber syndrome and Kleber-Tinoni syndrome and Close syndrome. If it becomes very disfiguring to the baby, we can offer the laser therapy. Here what we can see, this is also a common condition which is seen in babies, particularly the premature babies and babies with born from mothers with diabetes and pregnancy-induced hypertension, preeclampsia, premature babies. We can see this condition during the postnatal follow-up. So this is the infantile hemangioma. So these do not present at birth, but they appear later on, and they start increasing in size. There will be a growing phase up to 3 months. They can grow up to 12 months as well, and they regress gradually until 4 years. So this is the most common soft tissue tumor, incidence being around 4 to 5%. So if there are large facial or scalp hemangiomas, we should rule out underlying syndromes like FAS syndrome, where there can be posterior fossa abnormalities, infantile hemangioma, arterial abnormalities, coarctation of aorta, and eye abnormalities. If it is a small hemangioma, we need not do any intervention. We can do watchful waiting. And the other therapies for hemangiomas being topical application of beta blockers or systemic beta blockers, corticosteroids, and surgical intervention being laser therapy and surgical excision if there is a high chance of bleeding or airway involvement, which is life-threatening to the baby. For small skin lesions, we can just do the waitful watching. So the complications of these hemangiomas being, sometimes they can ulcerate, they lead to disfigurement. Even if they regress and slowly fade out, they will not completely become normal. The skin will not completely become normal, and there might be small telangiectasias which lead to the emotional disturbance for the child, and they appear disfiguring. So then they need some therapies, and if they are in the periocular area also, they can affect the vision, and auricular also can affect hearing of the child, and also airway hemangiomas are particularly life-threatening, which need immediate evaluation and treatment. So there are some other miscellaneous conditions which we normally see in babies. The first is the preauricular skin tag. We will also sometimes see the preauricular sinus. They tend to be autosomal dominantly inherited and run in families. If they are bilateral, they can be associated also with renal anomalies. So it is, whenever we see such conditions like preauricular sinus or skin tag, we should do the proper hearing assessment and also evaluate for the renal anomalies. So this is a sacral dimple, so which is seen usually in the lumbosacral area in some neonates. We should evaluate if the base of the dimple is not seen, or any abnormal neurological examination, like if there is any issue with the movement of the lower limbs of the baby, or if the size of the dimple being more than 5 mm in size and located more than 2.5 cm from the anal verge or out of the gluteal cleft, or it is associated with any hypertrichosis or hairy patch, or subcutaneous mass or a caudal appendage. So in such conditions, we should do the ultrasound of the sacrum followed by MRI of the spine if there is any doubt in the ultrasound of this sacrum regarding the spina bifida. Sometimes we see supernumerary nipples along this nipple line, which can extend from the axilla to the pubic region. Along that line, we can see supernumerary nipples. These are harmless conditions, so we can just reassure the parents. There are some hereditary disorders. I'm not going into detail of each of those conditions because each of them was a lengthy condition, and for want of time, I am not going into the details of these, like ichthyosis, epidermolysis bullosa, ectodermal dysplasia, incontinentia pigmenti, neurofibromatosis, albinism, and porphyrias. Occasionally, we also encounter such kind of conditions in certain babies which need proper evaluation and treatment. So coming to the vesiculobullous lesions, as we discussed, they can be non-infectious transient conditions like sucking blisters, miliaria, neonatal acne, erythema toxicum neonatorum, transient pustular melanosis, and acropustulosis of infancy. They can be non-transient bullous dermatosis as well, like epidermolysis bullosa, Langerhans cell histiocytosis, pemphigus vulgaris, mastocytosis, and hyper IgE syndrome. We will see in detail about the infectious vesiculopustular dermatosis. Either it can be a viral like herpes simplex virus, varicella, cytomegalovirus, bacterial infection like group A, group B, streptococcus, Haemophilus influenza type B, Staphylococcus aureus, Listeria and Pseudomonas can also cause vesiculopustular lesions. The others being syphilis. Whenever a baby is born to a mother having active congenital syphilis, we should look for the vesiculopustular lesions, and scabies and fungal rashes like Candida and Aspergillus. We will see some of these conditions. So here we can see some lesions over the lower abdomen of the baby. We can also see some superficial flaccid bullae with crusting around the bullae and vesicles. So this is the condition called as bullous empatigo. So this is caused either by Staph aureus or group A streptococcus. If it is limited to the skin of the baby, so then we can treat it with a topical mupirocin or other local application of antibiotic creams. So these appear as vesicles or bullae or pustules with an erythematous base. They are generally pruritic. They form a honey-colored crust. So if we do the gram stain from such lesions, we can see gram-positive cocci. So moving on to the next condition, here we can see erythematous lesion over the genitalia of this baby. So this is staphylococcal scalded skin syndrome. So this is due to generalized infection by Staphylococcus aureus. Here the presentation will be, the baby will present with temperature instability, lethargy, irritability, skin tenderness, and erythema. So here we can see a diffuse erythematous rash with the peripheral peeling, and sometimes it can also be seen with fissuring and crusting. So periorificial crusting and fissuring is also seen in these babies, but oral mucosa will be spared. This is a crucial differential diagnosis between the epidermal necrosis, in which the full epidermal thickness blisters will be there, and full involvement of the oral mucosa and mucosal areas will be there. So if the flaccid bullae with desquamation can be elicited in these babies by just stroking the periphery of the skin, which leads to the erythematous and painful denuded skin. This is called as Nikolsky sign, which is seen in staphylococcal scalded skin syndrome. So here we see on the back of the baby lesions with peripheral scaling. So this is the congenital cutaneous candidiasis. This is more often seen in premature babies. If it is inherited from the vaginal or genital flora of the mother, if baby is infected from the vaginal flora, it is usually seen at birth or within the first 6 days of life. It is seen as the erythematous macules and papules with vesicopustules with background erythema, more over the back of the baby, but it can also be seen all over the body. There can be also palmoplantar pustules and paronychia. Nail involvement will also be seen. If we do the KOH mount from these lesions, we can see for yeast and pseudohyphae. So this condition should be treated with topical antifungals and also intravenous amphotericin B to prevent the systemic candidiasis and also control the symptoms of the same. Next, moving on, this we commonly see in our OPD practice and our day-to-day practice. So this is the tinea infection. So we can see a circumscribed erythematous lesion. This usually occurs due to the lack of innate immunity in areas where it is moist and humid. So if the baby is subjected to broad spectrum antibiotics and frequent application of tapes, this can also be seen in NICU babies. Otherwise, in NICU babies, this is a less frequent condition. So only babies who are subjected to broad spectrum antibiotics, we can see the tinea capitis corporis. So this can be due to the infection due to the Strychophyton and Microsporum species, can be treated with topical application of azoles or terbinafine cream. So next, this is a blister with an erythematous base with surrounding broken vesicles. So this is the congenital HSV infection. Herpes simplex virus can cause this severe kind of infection. It presents in various types like SEM, where the skin, eyes and mucosal involvement will be seen. Or it can present with an encephalitis with or without mucocutaneous disease, or a disseminated disease with multi-organ involvement. These are the three different varied presentations of a congenital herpes simplex virus infection. We can see clustering of vesicles on the skin, eyes, which are associated with pain, and also baby will have keratoconjunctivitis and oropharyngeal ulceration. Complications of HSV being chorioretinitis, lethargy, and seizures. So this is usually seen around 10 to 14 days of life. If a baby presents with lethargy, seizures, and disseminated intravascular coagulation with associated with shock and hepatitis, we should have a high induction of suspicion for herpes simplex virus infection, which can be a congenital, that is, which can be transmitted from the maternal genital tract. So if we do the viral isolation or PCR from these blisters or vesicles, we can detect the viral DNA, and we can also look for the virus in the isolates. So treatment is with injection acyclovir, which is given for usually for 21 days. This can be prevented by having appropriate skin care and by improving the overall condition of the baby by having good nutrition and good NICU protocols. So here we can see the vesicles on the over the skin of the baby. So this is a neonatal varicella. So baby will be at high risk if mother gets infection, chickenpox infection, 5 days before to 2 days after delivery. Baby will have 20% chance of getting the neonatal varicella. So we should isolate the mother and also the baby. So the baby is also susceptible to go into severe disseminated varicella, which has a high mortality rate of 20 to 30%. Due to pneumonitis, encephalitis, thrombocytopenia, and hepatitis. So, if we see a baby with the history of maternal varicella 5 days before to 2 days after delivery, we should give immunoglobulin, varicella zoster immunoglobulin, 62.5 international units IM if the baby is less than 2 kg and 125 IU/IM if the baby is more than 2 kgs within the first 72 hours. Or IVIG can also be given if the VZIG is not available in the dose of 400 milligrams per kg. So if the baby, if the mother had varicella before 5 days of delivery, then the baby is also gets the maternal antibodies, then the baby is at very low chance of severe disseminated infection. In such conditions, there is no need to for isolation, but the baby should be closely monitored. If the mother gets varicella after 2 days of delivery, then the baby should be kept in isolation and until the mother's the vesicles get crusted, and express breast milk can be offered to the baby. So this is about the neonatal varicella. So next here this is a very unusual condition which is due to the improper nutrition and improper provision of the micronutrients for the baby. So here we can see a rash around the oral cavity of the baby with the sparing of the lips, giving a horseshoe shaped appearance. So it is a erythematous rash over both the cheeks and also the skin. This is acrodermatitis enteropathica, which occurs due to the zinc deficiency. So it can also be inherited as an autosomal recessive condition with involvement of the 8q24.3 gene. The risk factors being a preterm baby on total parenteral nutrition without provision of the micronutrients, trace elements, and also seen in babies with a condition called cystic fibrosis. The clinical triad of the acrodermatitis enteropathica is alopecia, dermatitis, and also associated with diarrhea. So we can see this rash over the flexural, anogenital, and periorificial areas with sparing of the lips. And the low levels of alkaline phosphatase, a zinc-dependent enzyme, may clinch the diagnosis of acrodermatitis enteropathica. The treatment is with oral zinc sulfate in a dose of 3 mg per kg per day. So coming to the last slide of the presentation. So here we can see a small punched out area in which there is no epidermis and the subcutaneous fat or muscle is seen. So this is the aplasia cutis congenita. So this is also rarely but seen in babies occasionally. So it is associated with some conditions called as trisomy 13 also. There is a focal absence of skin at birth, which is usually in the midline areas, and the more common area associated is the scalp. It is also associated with incomplete closure of the neural tube, localized vascular insufficiency, amniotic membrane adhesions. These are some of the hypotheses postulated to cause the aplasia cutis congenita, exposure of the mother to teratogenic agents and intrauterine infections. It is also seen in condition trisomy 13, Patau syndrome. So here what we can do, we should observe the overall clinical condition of the baby and treat the baby. For this skin lesion, we should do proper dressing and prevent the localized infection. And later on period, we can offer the skin grafting. So that is all about the development and maturity of the skin, differences between preterm and term skin, and the importance of the skin and the skin care in the regular term babies as well as the preterm babies in NICU, and the different breakup of the skin conditions, the benign and the more complicated conditions. So by observing the skin of the baby, we can know the overall health of the baby. So it offers the overall view about the health of the baby just by seeing the color, the perfusion, and the cyanosis, mottling. So we can know the condition of the baby. So we should always be alert and in looking for the different conditions of related to the skin and also the systemic conditions associated with the same. And we should practice the skin friendly care for the overall improvement of the health of these newborns. Thank you for your patient listening. I think this presentation will be useful for all the students who are preparing for their exams. These may be shown in the spotters or in the OSCEs. So thank you for your listening. So this is the last one. This is the diaper dermatitis. So which we generally see. This is due to the humid environment in the diaper area of the baby. So it can also be associated with the fungal infections. So where the skin gets inflamed upon getting in contact with the urine, feces, and excessive moisture and chemical irritants. So there can be an erythema and mild scaling, and in severe cases where there are erosions and plaques, it is also called as Jacquard dermatitis. So there are well demarcated patches, plaques with satellite lesions. Then we should think of localized fungal infection. The treatment is just leave the area open, apply skin barrier creams and zinc oxide creams, and if you suspect a fungal infection, you should treat the same. So this is an overview about the different skin conditions.